All right, just letting a minute go in so we can welcome everybody in, just have this thoughtful conversation. Good morning or afternoon, I don't know where everybody is coming from today. Welcome to our Friday webinar. This time we're going to be talking about the next steps in health equity and cancer care. We have our very own Mary Silber Murray, who will be moderating this panel. She leads our cancer working group at National Minority Quality Forum. And we have two speakers, two that you're probably very familiar with. One is our very own CEO and founder, Dr. Gary Puckrin, and then a woman that we work with a great deal in a variety of ways, whether it's through the Black Women's Health Imperative, the NMA, our very own Tammy Boyd. And I'm claiming you, Tammy, as a part of the NMQF now. One quick announcement for you guys. We have our annual 40 under 40 applications up and available. They need to be turned in by February 7th. So we're hoping to have a new class. I think this is our 7th class to 40 under 40. So hopefully if you're interested, please apply. And with that, I will turn it over to Mary.
Thank you so much, Brandon. Well, I'm really excited to be here. As Brandon said, I'm chair of the NMQF Cancer Working Group, and our topic today is really very close to my heart, and I think to the heart of the Cancer Working Group, because we're focused today on the Medicaid population. We know that in less than a month, the Clinical Treatment Act will become effective. And that act requires Medicaid programs in all 50 states to cover routine care costs for cancer clinical trials. And so that's why we're here today, so that we can talk about the act, but also strategies for engaging the Medicaid population in order to advance health equity. Few housekeeping notes. When you look at the bottom of your Zoom panel, you'll see a Q&A box and you'll see a chat box. So please put your questions into the Q&A and we'll be monitoring them so that we can put them into the conversation, but we will definitely have a end of the session, the last 10 minutes or so of the session, for more audience Q&A. So please put your questions in there. And then in the chat, we wanted to reserve that for different links to information that will come up as we're having our discussion. So as Brandon mentioned, we're joined by Gary Puckrin and Tammy Boyd, and we're going to cover the Clinical Treatment Act and its requirements and implications. We're going to talk about some of NMQF's priority cancer equity initiatives. We'll intersperse mostly in the chat some of the activities of the Diverse Cancer Communities Working Group, which we call Cancer Working Group for short. And we'll have considerations throughout for engaging the Medicaid population. So without further ado, I'd like to introduce Gary to say just a few words of opening remarks on this topic.
Thank you so much, Mary, and welcome, Tammy. We always love working with Tammy, and so glad she's able to join us this afternoon. I want to talk to you a little bit about what's going on in the world of cancer and why we should be extremely excited about the opportunities that are starting to come before us. So as you know, in 1971, then President Nixon declared a war on cancer. And I feel as if now we're at the beginning of the end of that war. There are some new technologies that are coming on stream, screening devices that are able to diagnose 50 cancers at one time. So with one blood draw, you're able to diagnose someone for 50 different cancers. And many of those cancers, we've had no screening at all before. Right? So that in its own right, the fact that we would now be able to, for example, screen for something like pancreatic cancer, which because we've had no screening devices, the survival rate is very low. Certainly the problem in the African-American community and Hispanic and poor communities generally is that they get diagnosed late for cancer. And late diagnosis for cancer means that the cancer has metastasized. It's moved from one particular part of the body and spread all over the body. We really don't have good science to help people survive that experience. We can slow it up a little bit, but the survival rates are really poor. Where we are successful at is in early stage diagnosis. And so that's why you hear we need to get people diagnosed early because of the opportunity to really improve survival rates. Unfortunately, we haven't been able to do that with minority communities. What's also important about those multi-cancer early detection screening, MCEDs, is sometimes what they're referred to, is that they also have the capability of diagnosing patients with cancer before the patient is symptomatic, before there are any clear signs of the disease. And so what that means is we are developing the capabilities to move from late stage diagnosis of cancer to early stage diagnosis of cancer. And that signals really a dramatic change, not just in cancer care, but in healthcare more broadly. I liken it to the period when we didn't have microscopes. And so we couldn't and didn't understand the role that bacteria and viruses played in our healthcare. And we couldn't design the antibiotics in order to arrest. Those MCEDs are our new microscope. They are helping us to diagnose patients early. And everything I see on the horizon is that we will start to diagnose diseases, not just cancer. Obviously, cancer is sort of the frontier of this, but we will start to diagnose diseases, diabetes, kidney disease, cardiovascular disease, before the patient is symptomatic. That is so incredibly revolutionary. And so it changes medicine in the same way that the microscope changed medicine in the 19th century. It'll do that in the 21st century. And so you just have to be excited about that, but it also raises tremendous challenges because think of the program like Medicaid. Right now, and this number has always surprised me, 90 million Americans are in Medicaid, right? Which is an incredible number if you think about it for a second, because Medicaid is a program where you can only enroll by income, and it means that your income levels are very low, and so you have to enroll in Medicaid. And those 90 million Americans do not count all of the people who are potentially eligible for Medicaid because, with the Affordable Care Act, we expanded Medicaid eligibility in a number of states. And so the states that have not taken on the expanded Medicare, if we included them, it means that 104.5 million Americans are Medicaid eligible. 1/3 of the American population, right? 1/3 of the American population are poor enough to be able to be Medicaid eligible. That should scare the bejesus out of you, right? Because it says something's very, very wrong with what's going on in our society. That's a whole nother conversation. But what's important here is they also will get cancer, right? And the way the rules and regulations are set up right now is that they would not be eligible for these MCEDs. And when I say these MCEDs to you, I'm not talking about something that's going to happen tomorrow. There are MCEDs on the market right now. Right now, people can get tested for cancer and get it diagnosed early right now, except if you're in Medicaid, you can't afford it, and the government ain't paying for it, right? And so automatically there's a disparities. In the African American community, there are 16 million African Americans, almost 17 million, about half of the African American population are on Medicaid. In the state of California, 63% of African Americans are on Medicaid. Think about that for a second, right? And so we have a very serious problem when it comes to equity, because as we bring these MCEDs into the marketplace, those who can afford it, on commercial insurance, got money in the back pocket, can pay for it, will get diagnosed for cancer early. And those who can't afford it will get diagnosed late. And all we're going to do here is exacerbate the survival rates of cancer so that the poor and minority of their risks for dying for cancer will continue to grow, comparatively speaking, to those who have access to the MCEDs. So we have a tremendous amount of work to do here. Certainly one of the great and important advancements is this new law, and I know we're going to talk about it in terms of being able to get treated while you're in a clinical trial. And cancer clinical trials would be inclusive of that, because those MCEDs are going to require a lot of research. There's a lot of knowledge gathering that is going to have to happen as we literally change the practice of medicine, going from this late stage to early stage, and even more importantly, treating people before they're symptomatic. We at the National Minority Quality Forum, we are really aggressive about this. We see that there's a tremendous danger right now that we will start to see an exacerbation of the inequities in our healthcare system as a consequence of the changes in science and our capabilities. So anyway, we want to have a conversation with you about that. I know Tammy and the folks at the Women's Health Imperative are a tremendous partner and are anxious about this as anyone else is. And so really glad to have this conversation with you this morning. Back to you, Mary.
Thanks, Gary. And Tammy, if you could also make some opening remarks, and go ahead, you go.
Yes, absolutely. Thank you, Mary. And thank you, Dr. Perkins. It was always great to partner with and collaborate with the National Minority Quality Forum. You all are just such important allies and partners with the Black Women's Health Imperative, and also Brandon Garrett as well. So I'm Tammy Boyd with the Black Women's Health Imperative, as mentioned. For many of you who may not know, the Black Women's Health Imperative, we are a national organization focused on advocating for Black women, the 22 million Black women and girls, through research, policy, and advocacy. And I'm in our policy, oversee our policy area. And we have several policy priorities. But one main policy priority we have is inclusion of Black women and minorities in clinical trials. But as you know, the health disparities for Black women really run the gamut. So we also are very interested in some of our priorities are breast cancer. We recently launched a campaign around mammogram screening with Mary J. Blige. We also cervical cancer, encouraging cervical cancer screening. We did that with Sierra about 2 months ago. So we also use celebrities too to amplify much of our work. And then we do what we often do with National Minority Quality Forum. We work in coalitions, many advocacy partners, and really bringing together multi-stakeholders to address many of the health equity issues. But similar to the Minority Quality Forum, we are very interested in really addressing any of those access and barriers for minorities participating in clinical trials.
Thank you so much, Tammy. And and Gary, and I'm excited to start this conversation because you've both teed up really the urgency of this issue. And so the moment that we're in is that we're about to see the Clinical Treatment Act enacted. I mean, it's enacted, I guess, become effective. And so Tammy, let's start with you, and maybe you can tell us a little bit more about the Clinical Treatment Act and its implications for engaging Medicaid population in clinical research.
Absolutely. So sort of to back up, I mean, as many may be aware, the Clinical Treatment Act, HR 913, successfully became law. It was a part of the FY fiscal year 2021 package in the COVID response bill. And so what that did was it guarantees coverage of routine care costs of clinical trial participation for Medicaid enrollees with a life-threatening condition. And as Gary mentioned, you know, just the statistics or stats in terms of minorities that are in the Medicaid program. And so, you know, it's an important requirement. It really ensures that our enrollees are able to participate in clinical trials, and really is the same manner that Medicare enrollees are, or commercialized commercial insurance plans. And so, you know, under this law, routine patient costs for items and services furnished in connection with a qualifying clinical trial are treated as medical assistance under the Medicaid program. And so therefore, a Medicaid covered benefit. And so although some the items of the medical assistance are optional, for example, adult dental services are an optional Medicaid benefit, but the routine clinical trials costs that's in this provision, it will be a mandatory benefit. But I do want to go back again and highlight that this provision will now become effective in 2022. And so again, this is really, you know, in terms of implications for the Medicaid population, as mentioned, Medicare and other plans already covered, but it's not covered for the Medicaid population. And I think COVID has really shown us that, you know, the importance of being able to understand and include minorities in clinical trials so you can really understand what's happening in terms of diseases, in terms of how the communities are being impacted.
Thanks. And Gary, if you could sort of piggyback on that and tell us a little bit more about, you mentioned in your opening remarks a lot about the general statistics about the Medicaid population, but why, from your perspective, is it important for Medicaid beneficiaries to have this now 50 statewide access to clinical trials, where it was very variable before? It really mattered where you lived. If you were in Medicaid and had cancer, what your options were.
So anyone who's been around the discussion around healthcare equity in our society understands that we have to increase diversity in clinical trials. You know, it's not just for those medication and devices that come on stream, but what often gets lost is that the clinical guidelines that are written on how to treat diseases are informed by those clinical trials, those drug clinical trials. And so, and then the performance measures that the government wants to reimburse on are built around those clinical guidelines. So the whole apparatus of our healthcare system really starts with the science and in the clinical trials. You know, historically, the problem has been that we've had underrepresentation of minorities in clinical trials, and some of it is structural, right? So if you have, you know, 16, 17 million African Americans in the Medicaid program, and you want to do a clinical trial that would include them, but the system is not going to reimburse the standard of care. And understand what that means is that this is care that if you weren't in the clinical trial, the Medicaid program would have paid for, but because you're in a clinical trial, it's kind of they opt you out of that care and sort of presume that you'll get it from the trial sponsor. And so this is an important step forward as we march towards getting greater diversity in clinical trials because we need the science. We can't really manage these diseases without good science. So This is a really important step forward, but there are other barriers out there and we got to bring them down. Unfortunately, you got to do it one at a time. I wish somebody would stand up and say, hey, we just get rid of a whole bunch of this stuff. But this is really certainly a great step forward.
And Tammy, I wonder if you can talk more specifically about how the Black Women's Health Imperative looks at clinical trials and what needs to change to get this inclusion and to happen, to really start to see more inclusion and participation of Black women and other minority populations in clinical research.
Yes, thank you. It's a great question, Mary. So at the Black Women's Health Imperative, we are looking at clinical trials from several on our research policy aspect programs. So for example, we have a PCORI grant where we looked at clinical trials and we actually conducted several focus groups to really understand from the patient perspective why, what are some of the barriers that are seen in terms of clinical trials from their perspective and why they may or may not participate. And so we hear a lot what has already, sort of been documented. But for example, we have heard, a lot of minority patients, when they go to see the doctor, they're not even offered clinical trials. Likewise, we've also heard, for example, when sickle cell patients go, which I think there have been a few articles about that, when they talk about their pain, they're seen more as drug seeking versus trying to, provide medications to treat their pain. And then we also, in terms of diversity, equity, inclusion, we've also created a rare disease diversity coalition where we've brought together several different stakeholders from patient advocates, diverse equity groups, and patient advocacy groups. And so a part of that, our work streams, one of our main groups is around clinical trials, researching clinical trials. And in that, we had a principal investigator or clinical trial investigator, minority come and speak to African-American physician, speak to us about some of the barriers, even from that end that he experienced. And so, for example, he says, well, it's taken me 10 years to finally get, awarded or into the clinical trial system. And he also had his clinical trials coordinator there as well. And, we are now looking at a way to address that barrier, which is, creating a training program or a mentoring program where you can look at, just some of the infrastructure pieces that it takes to have a clinical trial. He talked about how you have to be very exact and meticulous, your practice in how you're collecting data for the clinical trials. But then on the opposite side, from the patient perspective, in the Rare Disease Diversity Coalition, we are looking at how we empower patients to ask questions to their physicians, to their healthcare providers. So, there's definitely not a one answer solution, but I do think this legislation, or this law now goes a long way in sort of addressing one by one those barriers. And so again, it becomes effective in January 2022. But it's a key provision that we are also supporting and excited about and amplifying as well.
And just to follow up on that a little bit, you mentioned, that we're looking for diversity of participants, but we're also looking for diversity of investigators and inclusion of more providers or research clinicians who serve minority populations. And so, Gary, you recently published a commentary with Janet Woodcock and JAMA about expanding the clinical research enterprise to include more community physicians and providers. And so I wonder if you could talk a little bit about that, how that might help to diversify not just the patient participant population, but the investigator population as well.
Sure. So first, the article is actually in the New England Journal of Medicine.
Oh, I'm sorry.
Yeah. So our clinical enterprise system has really failed. I think you got to give it a failing grade in terms of addressing diversity in clinical trials. It's not that there haven't been efforts. I've been around long enough to see various efforts, but they've been one-off efforts. They've not been really a systematic effort. And I agreed with Commissioner Woodcock that we need to bring community clinicians into the clinical trial enterprise system, because they're the trusted voices in community that can recruit patients, hopefully as a part of their normal practice of medicine. So what we've decided to do is we are launching the Alliance for Representative Clinical Trials. We are standing up clinical trials in minority communities. It comes out of work that we were doing in COVID. We had a grant from Centene to do a 5-year study of the impact of COVID on minority and rural communities. And so we were partnered with 5 FQHCs, and we were doing that clinical study that really brought us into the clinical trial world. But we've partnering up with a CRO who will actually conduct the trials, but also train community clinicians. So we're putting the CRO with the community clinician, those who want to do clinical trials, to educate them on how to do a trial, but also do the trials right now. And so we've got about 5 studies in cancer, as a matter of fact, that we are looking to undertake that will be based in minority communities where we are going to be training clinicians who to become principal investigators. And we hope over time that we stand up a network. And the idea behind the network is that we'll go beyond cancer, that we want these trial sites, if you will, to be literally in minority communities, and the opportunity for expanding science and doing community-based research is there. And I think it is our way of moving from the conversation about diversity in clinical trials to actually doing something.
Thank you. We had a question to just explain the acronym for multi-cancer early detection that you were talking about earlier, MCED. So it's MCED stands for multi-cancer early detection. I just typed that in. I do want to sort of say, so we're preparing kind of the infrastructure among minority serving providers to become investigators. So Tammy, maybe back to you. You had mentioned one of the barriers is, many people don't even get asked by their physicians to consider a clinical trial. It never comes up in the conversation. Do you think this act, this Clinical Treatment Act, is an opportunity to go back to physicians and let them know about what it covers and why it's important for the Medicaid population, and to help expand that access and maybe stimulate that conversation?
Yeah, absolutely. I think it's very important. And even to also comment on Gary's, what he mentioned about the teaming up with a CRO and the clinical trials, other the providers. I mean, I think that's amazingly important, because, as we know, even the design. So hopefully, from that, even the CROs will learn from teaming up with minority providers. Yes, I mean, one of the things, any opportunity to educate and to amplify, the new law to providers would be excellent. So yes, I think it's definitely very helpful to do that. But then also, again, to even for the patient, to educate on that side, right? So they can be empowered to know, hey, that this is covered. So I think however we can, send out to groups, to send out, do forums such as this to really elevate the conversation, to make sure that, people in the community are aware of this, and definitely to physicians. I mean, we talked about, mentioned trusted messengers. I mean, so health providers and are definitely trusted messengers. They can also help with that message, educating them about it, but then also amplifying the message as well.
Mary, I just wanted to jump in to say, give a little bit broader understanding of what we're doing. What we're really trying to do is build learning networks, and clinical trials is a piece of it. But we'd like to have patient advocates in the network as well. If COVID has taught us anything, it's that we cannot leave community behind in the science, right? Because all kinds of really oddball things begin to percolate in community because we're not taking the time to educate people and keep them abreast of the science. So as we stand up these clinical trial sites, we want patient advocates to be a part of it, not only so that they learn and can spread, but they also can help design the trials, right? Because it needs to be understood how to do a trial in the minority community, issues of trust, culture. I mean, there's a whole lot of issues here that need to happen because we want trials not to be something unique in the community, but really part of the standard of care. And so the way we are working on this, it's a collaboration. We see this as a deep collaboration, which is what healthcare is. It is a collaboration. And so we also want to bring in referring physicians. There's this sense of competition that physicians may have. That's unfortunate because it slows up the ability to recruit patients into trials. It drives up cost. And so we've all got to get into this together because that's our future. That's the way we're going to not only address inequalities, but really take control of healthcare and get the outcomes that everybody's looking for.
I'm gonna actually jump to some of the questions in the chat because we're getting really good ones and I don't want to wait till the last 10 minutes to introduce them. So I'm going to start with one about the law since that's where we started the conversation. And so the requester says, not sure how to clearly ask this question, but the new law seems to risk creating pressure on potential trial participants to choose to participate because it will provide healthcare coverage. We are so concerned that clinical trial participants volunteer without any coercion or misunderstanding. Does the new law create inadvertent pressure? And if so, how can that be addressed? I'm gonna give a quick answer, and if I've misstated it, please tell me, but I think that it actually addresses disparity. So I think you had mentioned, Gary, if people are in Medicaid and they are diagnosed with cancer, their routine care costs would be covered by Medicaid. But if they enter a clinical trial, Medicaid at this point doesn't cover those costs anymore. And it either becomes an out-of-pocket expense for the patient, or the assumption is that the sponsor picks up those costs. So it's not that there's those, it's almost a disincentive to participate because you would lose that coverage if you joined a clinical trial. That's the current state that the law is enacted to correct. Is that the correct understanding?
Yeah, that's exactly the point. It's also true in the Medicare. There was a law passed a couple of years ago in the Medicare program that routine care would get covered because it's care that you would have already gotten. It's not adding a new benefit. It's just making sure that the care that you would normally receive, you continue to receive.
Thank you. Tammy, did you want to weigh in on that? Do you find that misunderstanding happening?
I would say yes. I mean, but I definitely agree. I think you and Dr. Perkering articulated it well.
Okay, thank you. So now the next question, I'm going to read it first and then you tell me who wants to go first. Many initiatives for increasing the number of qualified physician investigators in clinical trials focus on funding mechanisms through the NIH, DoD, NIAIDS, et cetera. However, industry-sponsored research has quickly become the largest funding mechanism for clinical trial sponsorship. There is a gap in connecting inexperienced investigators to industry sponsors. Does NMQF have any plans for initiatives to educate, train, and connect interested physicians to industry trial sponsors? So, Gary.
Yeah. So the work we're undertaking is really working with industry to train a new cadre of investigators who are treating minority patients. These are minority serving physicians who are in community, who we are connecting to the commercial sponsors. Which is not to say that we also will not reach out to federal agencies, NIH specifically, and others, to also increase diversity in clinical trials. Right now, excuse me if I'm being too frank, but the academic centers have a headlock on NIH, and they've not done a good job of diversifying their trials as it relates to minority communities, and that's okay. There are other options, and they should be allowed. So we're not just saying that we want to work with industry sponsors. We want to diversify clinical trials. We want to build a broad collaboration. It's going to take a lot of folks working at it, but I think that's just the plan.
Thank you. And I will just add that the NMQF's diverse, we call it the Cancer Working Group. I already gave you the big long formal title in the beginning of the session, but the Cancer Working Group did publish 2 papers just over a year ago around best practices at investigator sites for engaging, or for improving inclusion in clinical trial participation. And so many of those best practices refer to having good training for matching up referring physicians with the clinical trial, investigators and stuff. So there's other best practices as well, but we put the links to those papers in the chat. I want to get to resources that are available now to understand where the Medicaid population is, and also to start to use that to develop initiatives. So Gary, NMQF does invest in Medicare and Medicaid data, and through the Diverse Cancer Communities Working Group, we do have 6 cancer indices that look at breast cancer, lung cancer, etc. I won't list all 6. And we'll put a link to ways to get connected with those indices in the chat. But can you tell us why this data is, and the way we're building the functionality in the indices is really important to help develop subsequent initiatives to engage the Medicaid population?
So I'll start with cancer. If you ever look at maps of cancer, breast cancer, colorectal cancer, prostate cancer, what you find is not a flat map in terms of the risk is similar across all populations. That some populations have higher risk for certain cancers. And so understanding the geography, if you will, of cancer, where the risk populations are, is a very important first step. Because at the end of the day, the purpose of our healthcare system is to lower patient risk. Really what we're all involved in is lowering risk for hospitalizations, emergency room visits, disabilities, mortality, et cetera. And so by being able to localize the risk means that you can put clinical trials in those places to help better understand why that risk is there. You can use the MCEDs to come in and try to get to early diagnosis. Once you find them, making sure that access to care is there. The 21st century is all about lowering risk, right? To the point where we're actually controlling health outcomes. I am baffled right now, quite frankly, about our leadership. They are, I don't know where they are. They're off in space someplace. And they lose sight of the fact that we're in the middle of a medical revolution that is transforming healthcare. And certainly what we want to do at the National Minority Equality Forum is to make sure that minority populations and poor people don't get left behind, that we want to make sure that the benefit of all this science is available. And what COVID has told us, it's not, that we're putting patients at risk for a whole wide variety of reasons. We have to really take a look at our legacy healthcare system and figure out how to reimagine it. And certainly the work that organizations like the Women's Health Imperative are hard at it. There are other minority groups around the country that are at it. We just need to come together now collaboratively. And I know for those who don't know, Gretchen Wortman on our staff, she's been working on some action plans that we can all use to actually get at these disparities and reimagine a healthcare system that is more focused on patients.
Tammy, I wonder if you could weigh in on that, because when we spoke, you also talked about data being a really important part of your efforts as well. So could you comment on that?
Yes. So in terms of, collecting data, just generally speaking for us, we're, an inclusion in clinical trials for Black women. For example, just even when you look at how many, we take breast cancer, for example, Black women don't get breast cancer more than any other than say white women, but they have a higher mortality rate. And so just really understanding the data there, but then also how that, and Dr. Parkman talked about some of the guidelines and how those guidelines transfer. Sometimes the guidelines don't necessarily equate with when we want to screen, say, breast cancer for Black women or cervical cancer. And Black women also tend to get more aggressive types of breast cancer. So the data is definitely very, very important. I mean, at a very basic level, it's important to even know where it's actually happening, where there's a higher rate of that disease, but then also, what particularly is happening, with the Black community, but specifically even going into what is happening with, African Americans, Asian Pacific Islanders, the Hispanic population. And again, we saw that with COVID. I know Congress was very, when COVID first hit in the pandemic, they were very aggressive in sending letters to CDC and HHS saying we have to collect the data on what's happening in our community. And that's the only way you can sort of tailor, some of the response and how do we address what's happening in the community.
Thanks. And I really want to focus on what both you and Dr. Puckrin said about guidelines, because Gary, you helped us see the picture, the relationship between clinical trial participation guidelines and the relationship to access policies. And Tammy, you just mentioned the guidelines around breast cancer, particularly for screening, are late. I'm going to paraphrase a little bit, are too late in age in terms of for many Black women. Is that the right understanding, that the guidelines encourage screening at a later age than you'd like to see for the population?
Yeah, and specifically also in cervical cancer. That is, we released like a comment letter on that. So yes, I mean, and there's just examples of that across the spectrum.
So that leads us to, again, the importance of multi-cancer early detection, right? So who's going to have access even to those technologies? How are the guidelines going to be developed around those technologies? Gary, maybe you could start to talk about, you referred to some challenges as those technologies get developed, but we can see what the benefit would be. We can see the benefit would be earlier diagnosis and introduction to care.
So several years ago, I can't remember the exact date, the Association of Black Cardiologists put together some guidelines for the treatment of hypertension in African Americans. For those who don't know, African Americans have the highest prevalence of hypertension in the world. There's no other group of people that have hypertension at the level that African Americans, somewhere around 62 and 63% of all African American adults are hypertensive. And so they put these guidelines together, which the system completely ignored, right? I mean, just like they might as well have not written them, the way in which they were treated. Several years ago, the gastroenterologist put together guidelines for colorectal cancer for African Americans, that they needed to be screened before the age of 50, which was then the standard because of the risk of colorectal cancer in African Americans. The system completely ignored it, paid no attention to it. It is time that we recognize that risk varies across our population, and the healthcare system cannot ignore those risks. I mean, it is part of that legacy system where they think that minority populations and poor people, we don't need to pay attention to their health needs, that we can write guidelines that norm to the majority, if you will, but pays no attention to other. And I think that moment has changed. We have to do two things. One is, obviously, we've got to get the guidelines written correctly so that we recognize patient variability. But number two, we have to make the healthcare system be responsive. The business of healthcare is lowering risk. And to ignore that, I think, is a social determinant of health, right? If you're going to ignore people's health requirements willy-nilly for whatever reason, I think it's part of what we should declare as social determinants of health and measure that and put the system to test. So guidelines are incredibly important, but we just don't need to write them and paste them up on the wall. They have to be used.
Tammy, did you have a further comment on that? It almost looked like you want to say something, so I don't want to.
Oh, no,
Okay.
I was agreeing.
Okay, good. I want to then go back to the multi-cancer early detection, just because we do have one remaining question in the chat here. Gary, is there right now a certain age for the serum blood draw for the cancer screening, or is that part of what needs to be developed in this new paradigm?
So, as I mentioned, NMQF, we've really are paying attention to these MCEDs. And one of the things that we recognized as we started to do the work is that there is no compendium that helps us characterize risk for these 50 different cancers that we now have the capability of screening. So we are working on that. And we think it's an important document because if you go through the literature, guidelines, et cetera, in them are the opportunity to identify patients that ought to be screened. So it's not opportunistic screening, which is very expensive, and you can get a lot of false positives doing that. But if you can highly target populations. And that, again, is all about the future, right? It is the ability to understand where risk exists and to take steps to mitigate those risks. And at least in the imagination of the folks here at NMQF, we think that that's the business of healthcare, that's what the job entails. Too often the conversation gets about financial risk, payment reform. If I hear about payment reform again as a innovative practice, my head will pop, because that's not what it's about. It's really about patients. It's all about patients. It's all about helping people live and conserve high quality, long lives. And I don't know any other purpose of the healthcare system beyond that. And so these MCEDs are giving us an opportunity to do something practical in the sense of attacking disparities that we see in cancer care by bringing all of the energy to bear, not just on the clinical side, but on advocacy, on access, education of patients, wherever the barriers lie. That's what these MCEDs give us an opportunity to challenge the system to do better.
Thank you. And then I want to just, we've only got about 10 minutes left. So you both mentioned in your remarks and answers so far, trust. And so how do we build trust, within communities, within the Medicaid population, so that we are building an integrated system where patients can be their own advocates and providers can offer all of the options available to them. Tammy, can you talk about how the Black Women's Health Imperative builds trust?
Yeah, absolutely. And so, many of us have known that, health disparities, that it's, been here with us. And so I think with COVID, but then also with the Biden administration coming in and immediately signing all of the equity executive orders, that it seems we now have a unique opportunity where we have, it's almost as if there's a new momentum to really address how do we, look at ways, and as Dr. Perkins said, reimagine the healthcare system where equity in addressing many of these disparities in equity. And so, what we're working and what we're trying to do is we are pulling together the coalitions, alliances, where you have multi-stakeholders and where everyone is at the table. The patients are giving a seat at the table. The providers are giving a seat at the table. In our rare disease diversity coalition, for example, we have the rare disease groups such as NORD and Every Life and Global Genes, but then we also have National Medical Association, National Hispanic Medical Association. And then we also have, for example, the industry alliance that comes together as well. But then partnering again, with National Minority Quality Forum on many initiatives. I know, outside of the cancer space, but around obesity, we are working in creating an equity group with co-chairing with the National Minority Quality Forum, again, to address, which disproportionately impacts African Americans particularly, but also the Hispanic community, but addressing those issues. So I think it seems that, it's, again, disparities have always been here, but it seems to be a refocused effort at bringing and creating collaborations, again, such as the CRO and the health provider and the clinical trial sites, bringing everyone together to sort of figure out what can we do better to address, and really leaning on some of those trusted, kind of deviated from your question about trusted messages, but leaning on some of those trusted messengers, which are the NMQF, Black Women's Health Imperative, the advocacy groups, and the physicians, your HBCU presidents, bringing those folks to the table and really letting them lead and also provide feedback and ideas around solutions.
Thanks. And Gary, did you want to address trust?
Yeah, so what the saying goes, trust is earned, right? And you have to earn it every day. Imagine for those who are not African American or Muslim or any minority group, when you walk into the healthcare system, you actually don't know whether you should trust that person in front of you. Your everyday experiences raises concerns. And so it's really incumbent upon the system to demonstrate that it is a trusted servant, really, because that's what healthcare is about. It's really serving the needs of populations. And you do that by working very, very hard to make sure, again, it's all about that risk thing, to make sure that people are getting optimal care, that the system is not leaving anyone behind. But when we look at the numbers, right, when we're talking about disparities that exist day after day, year after year, the inequalities don't change. And you have to understand that that's a product of a system. This is not random, right? These are not random events. These are aggregated events that are happening every year that we can actually do something about. We could actually wake up tomorrow morning and say, you know, we just want to do something different. And I think what the minority community is asking and looking for is trust. When I go into the clinical trial, can I trust my life to you, that you are going to take minimal risk to advance the science? When I come into your office for care, can I trust you? When I go into that operating room, can I trust you? When you write that prescription for me, is that the best thing for me? All along the way, trust has to be constantly earned by everyone in the system, and you know, there's no way around it. And for those who don't understand the minority experience, then you can't understand the risk that's felt when you come into the healthcare system and you really don't know who you're dealing with and whether they are operating in your best interest.
Thank you. And I'm going to ask Tammy to have the last word on what do you think a call to action should be? We've got different people from different functions on this call today. What's a call to action around engaging the Medicaid or low income population now that we have this opportunity offered by the Clinical Treatment Act?
One would be to reach out into different communities to really amplify the message about this new law. I mean, some may not, be aware of it, but to educate definitely your patients, but empower them to ask the physician, but then also educating physicians as well. And then you also utilize, I'll have to just definitely say this is my bias for Capitol Hill as being a former LD for John Lewis. I would say, definitely, even collaborate with your members of Congress and, in their districts, and utilizing even their platform in their constituency to really raise awareness around this law.
Thank you very much. Thanks to both of you for your comments today. I think you've given folks a lot to think about and to act on. We have put several links in the chat to resources and articles that produced by the Diverse Cancer Communities Working Group of NMQF, as well as a little bit beyond that scope. So please take a look at those. And we even have a link in there if you're interested in joining us in the Cancer Working Group. There's a link for you to send a request for that. Also, please notice that the nominations for NMQF's 2022 40 Under 40 Leaders in Health Awards are now open. So there's a link for that. Please share that with your colleagues. And as you continue this conversation outside and on social media, please use the hashtag Cancer Health Equity, all one word. It's in the chat, because that allows us all to stay connected in this conversation. So I really just, again, would like to thank Dr. Puckrin, Tammy Boyd for joining us today. I'd like to thank all of you for giving up possibly your lunch hour to be a part of this conversation. Thank you so much for your questions, and we'll wish everybody a good Friday afternoon and good start to the weekend. Thank you very much.
Thank you.